You've just gone to great lengths today to tell us that actually the original consultation on temporary closure, because it wasn't really temporary closure, it was emergency closure, that wasn't real. And then you've also gone to great lengths to tell us that actually the consultation on permanent closure, that wasn't real either, because actually we couldn't open it.
So I'm happy, Diane, to come in. Consultation and involvement is a statutory responsibility of all HSC organisations, and we have a consultation and involvement scheme which is signed off by our board that makes commitments to engage and involve with our public where we make significant changes. In addition, so that's a legal requirement. So in addition to that, there is a departmental circular that places more detail around that and places specific requirements on HSC organisations, trusts ourselves, SPPG, the department itself, PHA. And that circular deals with both what they call temporary changes and permanent changes. Now, it's a little bit complicated because the circular actually has changed over time. But at the time when the temporary change was made, and we called it the temporary change in line with the circular, to be in line with the circular, we did check in with the department about the need to consult. And the department advised us there was a need to consult. Now, what did we consult on? Our first consultation, the consultation on the temporary change, was not about whether the change should come back or not. It was to reach out to the public to say, is there anything else that we can do? We have had an emergency situation. We were very clear about, we had no consultants. We were clear about the problems that we had, and we were clear about the new standards. And the ask was, is there anything else that we can do? Is there anything else that the public would suggest? I mean, there was a by way of, we just want emergency general surgery back, and that is entirely understandable because it's a very, very difficult consultation to do, to go into a situation of, let's face it, people felt very strongly a loss of a service, and there was a loss of a service in a way, although that service had been re-provided to the public in a very safe way, through an ambulatory provision, remaining here in South West Acute Hospital, and an inpatient pathway which went to Altnagelvin Hospital. So Diane, it was an odd situation really from the get-go. The permanent consultation, I mean, we are required under the legislation to consult on a permanent change. It's very difficult to do that when the change has already happened. And all of the evidence would show, and it did show, and we covered this in the consultation document, all the evidence would show that the service that is now provided is safe, albeit there are compromises around patient experience, and we totally accept that, although we are now monitoring patient experience much more closely, and patients are starting to engage with us and giving us comments about that service, and they are generally very good comments that we receive. So I can't, Diane, unravel this into something that feels like a more normal customary consultation process where you give people lots of choices. It happened in the way it happened because of the circumstances that we were in and the legislative requirements that are placed on us and the requirements that the department itself places on us. I think it's quite an unusual situation in Northern Ireland.
Sorry, my apologies. My dogs are not in the room with me, but they are very, very loud if you keep hearing them. So my apologies. I just think that one of the things that we have to do, if we are to convince people that transformation is possible, and indeed we all agree that it's necessary, we have to be honest with people. And I'm not sure that that's where we've been. But we'll leave that, we'll park that one for now, because I do actually think that that's important. So then, whenever the minister tells you to pause the consultation because you haven't done the consultation right, I'm presuming everyone is aware that this consultation in the Trust's view only has one end product, and that is to continue with emergency surgery at Altnagelvin. Because the depth of feeling in Fermanagh is such on this. It is my understanding that out of the 30,000 responses to the hospital network consultation, around about 27 or 28,000 of those came from Fermanagh. Now that is some community mobilisation, and fair play to those that organised it, but it shows the real depth of feeling in this.
Teresa?
Sorry, Dan, could you just repeat the question for me, just please?
Sorry.
I was following your train of thought, but just your question, please.
So how are you going to consult on something which I think is evident from this conversation today that the Trust has decided is a done deal? What does the new consultation look like? What are you talking to people about?
So the consultation, the formal consultation on emergency general surgery was paused in July after the letter that was received by the Trust from the Minister. And in October, the 7th of October, Trust Board met and agreed that that consultation would not be paused, it would be closed. The Minister asked that we commence visioning work, of course to include SWA, but also to ensure that we fully outline the needs of the population of Fermanagh and West Tyrone. So the work that we want to do, Diane, is broad work across primary, community, mental health and hospital services to understand fully what this community values, what we can do to change services to services that they feel they need and value more within the hospital and outside it, because we span all of those areas in our provision, primary now with the 3 practices, obviously community, mental health and hospital. So it is to broaden the conversation with the public rather than view this as a consultation. We don't view this as a consultation, we view this as a piece of work that helps us understand and agree and co-produce with our public a vision for the future for this area across a whole range of services, Diane. We think that in that way we can set what a hospital needs to do within a community, within the needs of that community and with clarity about what that community values.
Okay, so, and again, this is important because, I mean, I think this is probably the first time that people have had this really open conversation with people in Fermanagh. There's absolutely no doubt about it that the degree of travel time and the feeling of being bereft and neglected by the Trust in taking services away from the hospital, and the fact that the Trust has a hospital where some of those, or 2 of those theatres, they're not properly commissioned. They're used for the elective framework, but they're not commissioned theatres. It's a bit of a mirage to say that we've commissioned the 2 theatres in the SWA, because actually they're only used for that elective purpose. And there's no investment in nursing staff as well. Is there going to be, in this conversation, and I must say I think Helen and Jimmy are completely right in that they want to talk about bringing back emergency general surgery, and you want to have an open-ended conversation on a wider vision. And I don't know where that meets in the middle, is the honest truth. But is there any intention of having a vision for the SWA that will invest in doctors, in nurses and in specialisms that will keep the hope of broadening and deepening healthcare in Fermanagh alive?
So I would very much hope, Diane, that the conversation that we have with the public would confirm a lot of the things that we know about this geography. And we've referred to them today already. We have a population that is growing older, as it is across Northern Ireland. We have fewer young people in the population as a workforce. We have, with an older population, a great deal of need across a whole series of disease areas. So diabetes, respiratory, renal, heart failure, but also loneliness, wanting to stay at home and have your care at home. I mean, when we wrap around people in a geography, it must be a full conversation, and we would really like to do that. It isn't something that's ephemeral. It isn't something that we will do for the sake of doing. We want to shape services that will suit the population of Fermanagh and West Tyrone. And that is a population that is older and has a range of multimorbidities and needs, who wants to stay in their home and be supported well or cared for well locally in another setting. So I think, Dan, just to kind of complete the issue about the two theatres, I mean, we would absolutely, in this role, and in my linkages with the Commissioner, and everyone knows this, have been pressing for investment to expand our theatre utilisation here in the South West Acute Hospital for a long time, including during COVID. For the first time, really, we have seen mainstreaming of waiting list initiative money, and that is now benefiting us. And I talked about the CT scanner here, I talked about the 7th consultant here. That is going to benefit people from across the West, not just in South West Acute Hospital, but across the West. We really need multi-year funding, multi-year budgets, in order to work with our independent sector providers so that they can plan and to use our theatres. And we need investment to make sure that can work well, efficiently, productively, and with good value for money, because in-year money is really not the best way to spend our money. It is very, very good to get any patient off a waiting list, and I would never refuse the opportunity to do that. But we would like to plan much longer term, and if it's not possible right now to build capacity ourselves with nurses, doctors, surgeons and the rest, then at least let us do it with the independent sector over a reasonable period, so that we can have a steady and reliable service and chip away at those waiting lists much faster.
Can I ask a couple, just a very quick question? So, are you still transporting patients to Altnagelvin in private ambulances?
We have 2 crews that are available here for transferring patients to Altnagelvin. One is a late morning to early afternoon crew, and one is around a lunchtime, I think, to late night crew. If they are not utilised for transfer of patients for emergency general surgery, those crews are utilised, as I understand it, Diane, to support local discharge of patients. So they will take patients to their homes or their nursing homes. So we attempt to utilise them as much as possible.
So are they Northern Ireland ambulance crews, or are they private?
They're private crews.
So so you're still using private,
correct,
unregulated ambulances to take people to Altnagelvin? Am I correct in saying that?
The decision about the suitability of a private ambulance as opposed to a Northern Ireland Ambulance Service ambulance is a clinical decision. It is based on the presenting patient, as I understand it. Brendan will keep me right, and the risks associated with that patient. No clinician here will ever have a private ambulance used that's not suitable for the patient presenting. I don't know, Brendan, if you want to add to that.
Yeah, so just to say, really, private ambulances transfer patients between every hospital in Northern Ireland on a daily basis. So this isn't something that's isolated to movement of patients between South West Acute and Altnagelvin. And if you don't mind, I'm just going to go back to your previous question. You asked about expansion of services. Since the temporary cessation of emergency general surgery, we've introduced breast surgery, ENT lists, which were never previously here. We have visiting surgeons, some of whom are Western Trust and some of whom are outside, who come and do gallbladder operations. We are trying to expand our upper GI elective footprint here. As Teresa's mentioned, we're appointing a 7th obstetrics and gynecology with the hope that we can start to increase the amount of elective gynecology work, because there's huge waiting times for women who are waiting for elective gynecology procedures, and potentially try and make this a regional centre because of the spare capacity we have in theatres. We're also looking at our trauma and orthopaedics colleagues and moving what we can from Altnagelvin out to both OMA and Southwest Acute, and we're in discussion with those consultants at present.
And again, I think just if I could add to that, the agreement that Brendan has secured through his own initiative with NIMDTA to, for the first time ever, place resident doctors here. One of the huge problems, again, in recruitment often is that if people don't have the experience of working in an environment, even though jobs are advertised, they won't come to them. So by bringing residents here who, as part of their training, spend time here, you build a familiarity and a sense of this community, which is very vital and very powerful. And then they see a place they want to stay in, or they meet someone, a partner that they stay in. So one of our problems here is getting NIMDTA to acknowledge that there is really high quality learning and training in this circumstance, which in itself enhances the morale of the place and gives that sense of a developing dynamic scenario. And Brendan now has got agreement that that will commence in August with the intake of resident doctors.
So just to clarify that, so
that's a brilliant segue, Tom, into my next question, which was really within the new cohort, the original cohort from McGee.
Yeah.
I presume qualified in the summer, if
That's
I'm
correct.
thinking right. And how many of those were we able to retain in the Northwest? Do you have any idea? Did the Trust employ more?
So they've been employed across Northern Ireland. My understanding is we have 10 of the McGee graduates who are currently working in the Western Trust. Just also go back to Tom's point. What I've done is, with the help of Dr. Monaghan, we've set up a pilot project with the agreement of the Chief Executive of NIMTA to bring Tier 3 medical doctors. These are quite senior resident trainees to the Southwest Acute Hospital. And this would be a huge development, because if we can get these doctors on site, it will mean it should be much easier to get permanent consultants as well.
Well, that's encouraging. That is really encouraging, because we really do need to invest in the workforce, not just, doctors, not just having consultants, but we need the whole remit of the workforce that we invest in. Can I just ask, there was a question mentioned today that there was some indication that there might be a downturn in elective surgery in the SWA over the winter period because of winter pressures. Now, I know that happens across Northern Ireland because just of the sheer pressure of numbers in the hospital. Is that likely to happen?
So, go ahead.
Well, I do unfortunately have quite a wide portfolio on emergency planning and business continuity. Diane is part of it, and what my team do is they support the winter planning preparations, although we now call them escalation plans. So very many of our patients, particularly at Altnagelvin and Southwest Acute Hospital, are clinically urgent patients, so they have conditions that make them time critical. So cancelling elective patients is an absolutely last step that we would take. And I mean, I've seen the efforts that our team make. We have a very, very tight, well-coordinated process which looks across our hospitals to make sure, it's called our coordination hub. It looks across our hospitals, it looks at all of the balancing factors when pressure builds in our hospitals, either in our ED, in our wards, or with our delayed patients. And there will be judgments made, which will sometimes actually be made at a level of our corporate management team. At those points in time, we would be into what we call our silver escalation, and we would assemble our silver command and control arrangements at trust level. So decisions about cancelling really get to a very high level within the organisation before we would ever, approve them. And I know we cancel tiny numbers of patients for elective procedures who are in those clinically urgent or time critical categories, Diane.
Have you reached that silver status this autumn so far?
We have had, I think, a series of about 4 days, probably about four weeks ago, where we did run silver. To my knowledge, no patients were cancelled over that period. And in those instances, a director will step in and will chair silver. It's a short meeting. It is to support the operational staff in decision making and escalation issues. And I mean, it really is a sight to behold how our operational and clinical teams pull together at times like that to ensure safe care and to ensure that the impact on patients of that very high pressurised situation is minimised.
And Diane, the 8 beds that I talked about in trauma are designed to actually help protect elective work during the winter period, because some of the pressure in relation to the emergency work is through trauma, and the general sort of conflict between trauma and orthopaedics. So to try to protect the elective work in orthopaedics, we've actually got commissioned 8 extra beds in trauma, and that then helps the flow of elective, so there's always, it helps protect the beds.
Can I say thank you? For those who know me, I just say the thing as I see it. And I think that people need to be spoken to about this particular issue, which is very vexatious in Fermanagh. And I know I don't live in Fermanagh, but I have a large cohort of family who do. And they need to be spoken clearly and particularly honestly about what has happened and what is possible for the future. I think that many people in the area feel abandoned by the Trust, and I think that there is a huge amount of work to do to repair relations. Thank you very much.
Chair, can I ask a yes/no question just on
Go
the
ahead.
back of that? Just and I've held off going to my next appointment to be able to get to the end of this. Can you give an assurance on a yes/no basis that there are no current discussions or plans to remove any other services out of the South West Acute Hospital?
Yes, I can give that assurance. Because, sorry, can I qualify it to say certainly no discussions involving the accounting officer of the Western Trust. So I don't know what other conversations other people can have. Yeah. I can only assure you in relation to any conversations with regard to the Trust, I would be astounded, because look at the great work this hospital is doing. Look at the fantastic, how we're expanding the specialties in this hospital. So why would anybody wish to take away any services from this hospital? I can assure you in that, Colin.
And that's really good, because there can always be a nervousness.
Oh, absolutely.
Service
and there's been
starts the process.
There's been a lot of talk.
Absolutely. That's good.
And just finally, anyone who walks through this facility, it is leading edge, probably the most modern hospital building in this region, significantly so. And by the way, it's operational, unlike some other new buildings. And the people in it take huge pride in it. And it depresses me that they would feel despondent or feel a sense of not being valued, because there is nothing further from the truth.
And the water system works.
Okay, that has been a long session, but I think it's been worthwhile. I said there was 17 or 18 issues that I had wrote down. The majority of them were covered, and we thank you for the time that you have given us and the answers that you have given us in relation to it.
Thank you.
Can I check?